I'm not going to be able to change the system.
Yeah.
But I have a hope that if I indoctrinate enough students growing up, they eventually will, through weight of their masses or because one of them is better than me down the road, and this is what all teachers hope for someday,
Right.
that I have seen students make these breakthroughs down the road.
Today I have the pleasure of interviewing Dr. Scott Wetstone, who's an associate professor here in the Department of Public Health Sciences, and I look forward to speaking with him. Good afternoon, Scott.
Hi, Doug.
Good to speak with you. I'm hoping we could have a nice conversation that captures some of who you are and what you do here at UConn Health.
Thank you.
Maybe we could start with where you came from, where you started, and what led you to the career that you're in currently.
Well, I did not take a typical career pathway, although I started that way. I am one of 4 children. My father was a physician at a time when it took a neighborhood to get him through medical school. And it was clear that he wanted me to be a physician. I have adages from when I was yay tall that I still quote today. But I'm local. I grew up in Bloomfield. I went to Wesleyan undergraduate. I went to UConn for my medical school training. And when I graduated, it occurred to me that I didn't really want to do clinical medicine. So I did a career, one of many career changes, but all the career changes took place at UConn. And so I went into research.
And why didn't you want to do clinical medicine? I've met other MDs who made that decision, but I think their reasons might have differed from each other.
Well, it was a decision made by someone in their youth and inexperience, in part. So it's not who I am today. But at that time, I thought I had a choice. I either had to be a great physician, which meant I had to become a monk and just spend all my time and effort. I had been indoctrinated by Dr. Welby's and other TV shows where the doctor was at the hospital 24/7, or I wanted to have a chance to have a life. And I didn't have the barriers at that time to think I could do medicine and also enjoy having a life. I would just spend all my time trying to do for my patients. So I made a hard choice.
Okay. And do you have different reasons today?
Oh, if today I've had a series of, I've had a wonderful career, and I've constantly been able to change it and shift it based on the needs of my institution. And therefore, my days are always interesting and fulfilling. I get to learn new things constantly. This is no diss on being a clinician, because you can be a clinician and still solve this issue, but some parts are routine. You do the same thing over and over again after a while. Maybe not an academic physician, but at the time, I've had chances to do so many different things, learn new things, meet new people, see different ways of doing things, that really had a very interesting career.
So you did your medical training at UConn, and now you're at UConn. Did you did something in between then, or have you been at UConn?
I've been at UConn every year. I've been at UConn every year. So I walked into this building in my summer of my senior year of college, and did a 6-month stint doing work here in research. I went back to college for 6 months, and I've been here basically ever since. So that means 52 years since I walked in the building. HR would say I have 47 years of permanent employment.
That's remarkable. I don't even know how to process that exactly.
Well, I'm a dinosaur, and some things about dinosaurs are good.
Yeah,
some things are bad. But my loyalty to the institution and my love of the institution, obviously, how often does someone spend literally their entire adult life at an institution?
So tell me something about what it is you love about UConn. I definitely appreciate UConn, but I've only been here 7 years. It doesn't even hold a candle to you, and I have no idea how I would feel if I had been here 20, let alone 30 or 40 years.
So my first love was UConn Health, not all of the university. That grew later as I had contact later. So it was the education system, I think, that really was the beginning of that. We had a system that was a organ system, which is an integrative model of trying to understand medicine, rather than starting with anatomy as a basic course and biochemistry. It was integrated from the start. And we had a non-graded system. At the time, to get into medical school was very highly competitive, maybe the toughest in history, where even at the best universities, only a fraction of the people got in. So your colleagues were your competitors, and once you hit the doors here, your colleagues were your colleagues, the people, the other students around. You weren't competing for grades. So that was a very big piece of the initial liking of what was going on. We all know we have a very nice physical environment out here in the suburbs, and what we can look at and see. It is very easy to get behind an academic health center mission where we're not putting a bottom line of any sort on the table. No one's interested. Maybe I should rephrase that. Making money is not the focus, particularly back then. It wasn't so competitive for the research grant side. The clinical side was much smaller. It wasn't an engine. It was really an academic institution, and everybody was giving up money by working here. So they were sort of a small group of people. We knew each other. There's a time I think I could have walked down the hallway and identified 80% of the people. That's long gone.
And when you came back, you were doing research?
So the research that I had started as a college student, as just a helper, was using computers, which were new at the time, for patient and physician education. And so I came back and started as a faculty member doing that.
And what were you in the precursor to this department? Maybe didn't exist, or did it?
This department did exist, but I wasn't in this department to start with. There was a very tiny department called Research in Health Education, and it had 2 tenure track positions and a couple of other positions. But soon after its inception, one of the tenured people was leaving. And so a decision was made to dissolve the department, and other departments said, I want you. And this department that we're in now, which used to be community medicine, wanted me. I didn't know this at the time, but they wanted to grab me so that I could teach a MPH course, statistics, at night.
And so at that time you were already focused on statistics?
No, not at all.
Why did they? Okay, I'm sorry to say it this way.
Why?
Why did they want you then?
Well, one, they were desperate. They wanted anybody. Okay. But two is, in my research, I realized I needed to learn statistics. And I had a colleague who was the head of the biostatistics center. So I said, in order to learn statistics, I will volunteer to be a co-instructor for the conference groups. And that I'll stay 1 week ahead of the medical students, and she'd really do the teaching and correcting. And so there was a perception that I understood statistics. And that's why they came and said, you can watch the course for 1 year and then you teach it. And 3 weeks before the course said, no, you're not going to watch anybody, you're just going to teach it.
And so you had to learn it very fast.
I had to learn it very fast.
Okay.
Which is why I teach it the way I teach it. I don't teach a traditional statistics course. And now we're talking over 40 years. And that's been one of the themes. My other pieces of my job have changed, but not my classroom teaching. I've been teaching classroom teaching for quite some time. And I had a different perspective on how to learn it because I didn't learn it using the classic models.
Well, my impression, I've never watched you teach it, but I've seen students coming through, is that your approach is successful, especially with public health students, many of whom maybe math and statistics is one of not their strongest suit when they come in. And so having, I think, your course, they get through it and they learn it. Am I right about that?
You were right about that. That it was the course that used to trip people up. If they were going to have a problem, it was because it was math in particular. And even math people don't like probability. So the probabilistic nature of it made it too confusing. I found ways to simplify it, good analogies, a lot of visual learning. But the greatest thing I was able to do was to get the institution to merge its epidemiology and biostatistics, because quite honestly, statistics is just a tool for the epidemiologist. It doesn't, in a medical school setting, sorry, statisticians, it doesn't, in itself, it has no reason. Its reason is to support epidemiological research. And so I was able to merge that first in the medical school and then in the MPH program, merge those two topics together. So in the MPH program, I think we're in like the 20th year of a merged course.
And if you had to characterize succinctly and for a lay audience what it is you do that makes the way you teach it successful for students who maybe come in nervous about math and bio and statistics, what is it? What is the core thing that you do that helps them get through that and succeed?
Well, I actually have a written philosophy about it,
okay.
which is in the preface of the book that I use to teach it for our students. But to simplify it is to say that I don't teach it using equations. I teach it using concepts. A lot of those concepts are pictures that show the concepts, and then we do a lot of application, a lot of applying it and building a sense of I can do this. In fact, probably what I appreciate most is the student who comes in very much afraid, very much maybe not even doing well, who ends up at the end of the 2-semester sequence saying, I want to learn more about this topic, and actually change their focus and concentration to it because they realize I can do it. A lot of times we're told we can't, we think we can't do something because we're told we can't. And when you find out you can, it's really rewarding.
Absolutely. Yeah, that really aligns with, in my research, I work with biostatisticians, but I'm not competent at the intricacies of the math, so I float at sort of a more conceptual level, and it sounds like that aligns sort of with your approach to teaching students to begin with. So I like that.
Well, and I've found that sometimes experts in their field, and this isn't just statistics, it includes epidemiology, but others don't actually understand their own fields. They are mimicking, parroting what they were taught as they were, without giving it some serious thought. And this is true in many fields. There's a barrier sometimes of entering a profession, which is the vocabulary. And we got a horrible set of vocabularies where the same symbol can mean 3 different things in different contexts. And learning that is just terrible for students. You got to simplify it. You got to make it easy. And some of it is you do it in a human way. So you admit to, I'm sorry that you could make a beta error finding out whether beta is actually 0. And I'm not going to define that for you now or for the audience.
Thank you.
You may understand it, but the audience might. But you can commiserate that, yes, this is unfortunate, but you still have to learn it.
Right. What keeps you enthusiastic about doing this? Because that's a long time.
Well, keep in mind that teaching is one thread of what I've been doing.
Okay.
I've spent major and significant time doing many other tasks. What keeps me interested in the education is I keep taking on new challenges. So, for example, teaching the same public health course year after year after year, I find new methods. But when we created a new medical school curriculum 10 years ago, to be able to help design the evidence-based decision-making portion of that, and to really take on more windmills, if you will, more conventional wisdoms that are not true. Make it more interesting, to take life events. COVID is just, the number of different ways we could apply our tool set to something that's recent, I think helps liven up the teaching piece. But as I said, I've had so many other duties that I did that teaching used to be 10%. Now it's all that I do because I'm part-time and chose to give up those other more administrative activities. But there was, it's only lately that's expanded. Earlier in my life, the teaching was a small component.
Okay.
So it was like if you said teach the same course 4 times a year, that would be hard to keep fresh.
Another thing that I think about when I think about you is that you are very insistent on adherence to evidence and not very not very willing to sort of take a leap of faith that something must be true because everyone says it or something like that.
So
Can you speak to that a little bit?
Sure. So there's a fairy tale, The Emperor and His Clothes.
Right.
I am not one to tend to believe something just because people say it's true.
Yeah.
So I'd like to see the evidence for it and make the assessment. There was a role model I had was a professor who's long gone named Bob Jungus, biochemist, and I can remember sitting at him at a lunch like in 1995 where he said, you know, that experiment done by Dr. X in 1955 doesn't make any sense given what we know. And he was rethinking the original stuff.
Yeah.
Probably my favorite piece of the teaching is journal clubs, is when we take some articles that establish, or one article I like in particular, that killed a method of childbirth. And just one article, one and done, it's never resurrected. And you can go back in the article and find the evidence actually says the opposite. And so this notion of going back. But there's a little bit of contrarian me in that I like using movies as analogies, by the way, in my teaching. Right. So World War Z has a concept called the 10th man. And in childhood, we have another fairy tale called Chicken Little that I like to look for the other side. Yeah. And that has been helpful in some of my jobs, because some of my jobs have been protect the university. And one way you protect the university is you think about what could go wrong. Let's have a contingency plan. Maybe that would be helpful in current events right now, that what happens if they don't do what you think they're going to do? And you think about why would they do it differently? And so that's a piece of it too. So I like to look at all the angles. There also is a skill that I see that many people don't have. A few do. They understand how tweaking this affects this thing over here. They only, most people can only see the one thing in front of them and not the interconnections of a complicated machine. And I've been fortunate to work with people who have that skill, like chiefs of staffs of the CEO, because you have to know how this decision over here, or a policy meant to tackle a little problem over here, is going to end up resulting in changing this, sort of like the butterfly effect, quoting another movie.
That was a lot of, you had a lot of connections. It's not always easy to take a contrarian, or maybe that's not even the right word, to take a hard evidence-based view of something that goes against something that is widely accepted and valued. You seem to do it and not flinch very much, if at all.
I do it more when I have less to lose. When I
think all
I needed to pay tuitions, I was more careful. I had one of my idols, Ioannidis, who is an national evidence-based decision guy, gave a talk here, and I won the lottery and spent an hour with him in my office. And I was talking to him about tilting at one of these windmills. And I still remember what he said. He said, "Don't do it, they'll crucify you." I do it. But more so now than before.
You've survived.
I've survived.
You've thrived, actually.
Well,
yeah.
To be honest, I know I could be at a different place right now here if I had played ball differently. But it's okay with me.
Okay.
Okay. I have my value system. Evidence is one of my values. Rule of law is another value. Ethical treatment of people. And that doesn't always mesh with the way things operate. But that's who I am.
I remember seeing you presenting something that was potentially controversial to medical students, and introducing some countervailing points of view to the widely accepted opinion at that time. And how much do you think you're able to impart that kind of value in the students you teach, or do they appreciate it and then they just go back into the general population, and depending on their personality, it doesn't stick? What do you think?
That is an insightful question or observation. Very often, I recognize that I'm not going to be able to change the system.
Yeah.
But I have a hope that if I indoctrinate enough students growing up, they eventually will, through weight of their masses or because one of them is better than me down the road. And this is what all teachers hope for someday.
Right.
That I have seen students make these breakthroughs down the road and begun to push and ask the important question down the road. And students are powerful in ways they don't know because they ask the question, why? And if we can encourage more people to ask the question, why? Slowly, can't change the whole environment all at once. The system won't allow it, but keep making those chinks then you hope that collectively, I have a phrase I like to use sometimes: the 100th hammer blow breaks the stone. You got to keep sending the message out, sending the seeds out, and that motivates me. And maybe that's what keeps me motivated, is I got to make more seeds to send downstream.
I hadn't heard that one before, the 100th hammer blow.
Yes.
Very cool. What else would you convey if you were saying something for one of our students, maybe an MPH student, but maybe medical students see this as well, who are coming up now? What advice would you give them based on your experience?
Think for yourself. I think we have a trend now of letting others do our thinking for us.
Yeah.
And whether the others be artificial intelligence or whether the others be how many likes are on an idea, and that's what determines what is truth and not truth, that I'd like to encourage them to remain individuals willing and capable of thinking for themselves, even if it's against conventional wisdom. That would be my hope, that that's what they could do.
That's great advice. Is there anything else you want to add? I feel like we've covered a nice range of things, and it was very to the point and clear, but what else would you like to say, if anything?
Well, be adaptable. I just give an example. My first real job here after my research job was to introduce something called desktop computing to the institution. I headed academic computing, and we built the Computer Education Center and the first networks in the wall, and word processing for instead of the type, we were talking typewriter before the camera went on.
Right.
The word processors came out. So you have to evolve constantly.
Yeah.
And I've had in many cases, so don't lock into anything. Be adaptable, and remember that you have to be a lifelong learner, and not fear it, but to embrace it.
And yet before the camera, we were also talking about that the emergence of AI is a little bit scary to both of us.
It's at some point you realize that you cannot live the adage of always wanting change. For example, in the last 5 years, I think our IT department has made us learn 4 different video conferencing systems. Sorry, I can't keep up.
I'm sorry you brought that up, but yeah, I'm not sorry, but yeah,
I can't keep up.
Right.
So
no.
I'm slowing down.
Yeah.
But I'm 72. I have a right to slow down.
Right.
So yes, some things I am beginning to worry about because they're moving too quickly. And I have adult children, and both are in IT fields. They're feeling the same. Everybody's feeling the same pressure. Yeah. No one has any idea, and sometimes it's nice to have rock solid ground.
Yeah.
For me, I have rock solid ground in my family, my wife in particular. I have rock solid ground in my values system, or in the tool set that I have for evaluating things. There are a lot of people that don't have rock solid ground. I don't have to worry about making a career any longer. My income stream is secure. Those who don't, and who are threatened, for example, by AI or something else, I have sympathy for. But so it's easier for me to say embrace it. But once it goes too exponential, it is a little scary. But then you're alive if you're, And the other thing, again, this is an old man thing, is you can't be courageous unless you're afraid.
Yeah.
You have to feel fear in order to be brave.
Right.
And it's an opportunity.
Right.
So let's be brave.
Yeah. You're reminding me of something I started saying quite some time ago, is I don't want to be heroic. It's the only reason you're a hero is if you have faced a really serious threat. Right. So it's similar, I think, to that thought.
Well, here's where I'm going to make the distinction.
Okay.
Many of our heroes never had fear.
Yeah.
And that doesn't make them brave or courageous.
Right.
You have to have fear to be brave or courageous.
Okay.
And so
I want to take that with me.
I understand. I wouldn't want to go through the trials and tribulations of necessarily being, quote, a hero or not. But we can be brave every single day.
Well, Scott, I think that's a great place to end this, if you don't mind.
I'm fine.
That was a beautiful ending, and really enjoyed talking to you, and thank you.
And thank you for doing these surveys.